Yes, a warm welcome to this year's Congress coverage from ASCO. ASCO is one of the largest cancer congresses, and ASCO stands for the American Society of Clinical Oncology. My name is Alexandra von Korff, and on behalf of Mamma Mia and patients today, I warmly welcome you. A special warm welcome to Professor Sherko Kümmel. Together, we have selected several studies that we believe are highly relevant from a patient's perspective, and we want to present them to you. There are also other takes on these topics available. In this take, we have one more study to present. And I'm really glad that Professor Kümmel has taken the time to discuss this with us. Welcome.
Thank you for the invitation, Alexandra. So I'll get started. My name is Sherko Kümmel. I head the breast center at the Essen-Mitte clinics. That's in the western part of Germany, so to speak, as part of a large women's center here in Essen. And now we have another study that we will discuss together. And this time it's not about how much chemotherapy or which other antibody or yet another new medication. Instead, today we're talking a bit about something else. The topic is de-escalation strategies. That means, and here, operate a de-escalation strategy to the point. Specifically, is it okay if I operate on fewer lymph nodes in the armpit? That should really grab everyone's attention to the maximum because, of course, this is something that interests everyone. These are the disclaimers. These are my disclosures, meaning conflicts of interest in this situation. And then there was the AXSANA study. What is the AXSANA study? The AXSANA study is a worldwide study, a registry study where patients could be included that is registered. They simply reported what they did with the patients. So it was not randomized where you do this or that, but rather it was reported by the colleagues what was actually done with the patients, so to speak, in the whole process. And several thousand patients were registered and everything was essentially recorded and then analyzed. That is, so to speak, what is behind it. What kind of patients were these? They were the ones who had lymph node involvement in the axillary region. This was confirmed by a biopsy in that situation. And of course, the question was, if you operate less overall, then it is naturally clear that there will also be fewer side effects. But that was not the focus of this whole thing. It concerns the group of patients for whom neoadjuvant therapy is administered, chemotherapy in most cases, that is, before the operation. And through this therapy, we know that if it works well, in many women, even though the lymph node status was positive beforehand, the therapy can change the lymph node status to negative. What does negative mean? It means that the tumor cells are also gone from the lymph nodes. And sometimes that happens even more often than the tumor cells disappearing from the breast. That means in the past, whenever it was said, aha, the lymph nodes are positive, at least 10 lymph nodes would be removed from the armpit. The concept that was first published in the scientific literature by Abigail Caudle and her American colleagues back in 2017, and on which all these studies, analyses, and more recent surveys are fundamentally based, is essentially that if after chemotherapy, the lymph nodes go from being positive to no longer showing clinical signs of disease, in the examination, it may then be sufficient to only remove the sentinel lymph node and the marked lymph node. Now, others say yes, it varies. In about 60% of cases, the sentinel lymph node is the same one that was biopsied at the beginning of therapy and, for example, had a clip placed in it, or marked it with charcoal. Yes, there's also medical charcoal used for this purpose, or with such localizers. What is that? Something is applied, for example, that has magnetic fields, or some kind of clip that can then be detected again, for example, with a Geiger counter by a beeping sound or by making it visible, so to speak. So what exactly is the so-called targeted axillary dissection, as it's called? If the lymph node changes from positive to negative, as just explained, then the sentinel lymph node procedure is performed. If in the sentinel lymph node, the clip-marked or otherwise marked lymph node, the one that was biopsied and identified at the time, is found to be affected, if it was included, then you're done with the whole procedure. If it wasn't included, you should remove it additionally. And together, that's what is called, so to speak, the targeted axillary dissection, or TAD for short, as it's called. And now, so to speak, in the...
yes, right.
Yeah, it's funny, isn't it?
I also find these terms at times.
Exactly. But I think that's why I'm taking the time to explain it to you right now. So specifically so that you know exactly where you are in the whole process. So several thousand patients, so to speak, from many countries over a period of 5 years, so to speak. And now they've selected these 500 patients from this registry study in order to address exactly the question that I just explained a bit. In the whole process, that means you have this marker, you recorded what was done for the marking in the whole process. They looked at how you actually find it. Some people know this, you're always looking for the clip. When the tumor cells disappear and the lymph node no longer appears dark on the ultrasound image, but looks completely normal, then it's not always the case that you can easily see the clip. Instead, it can just as easily hide among the normal lymph nodes, and sometimes you can't find it as easily anymore. So, how many lymph nodes are actually removed in total? Always keep in mind, in the past, at least 7 to 10 were always required. And those are essentially the results of this study. That means if you placed a clip, so to speak. The success rate was just under 90% for finding everything, as long as it was all compensated for. If you use markers, for example, this localizer as an example, magnetic markers, the rate was even higher, a few percent more, so almost 97%. But this coal was just as high. So the marker here, as an example, the localizer costs, I know, a few €100. The charcoal in principle costs €20. Now someone says, I'm not taking any money in this whole situation. This is medical charcoal, which is then injected into the lymph node so that it can be seen during the operation a few months later and specifically removed. And you can say that was the biopsied one. So it's also a simple method overall, which especially our colleagues from Rostock have researched a lot and helped to develop. That was once again the planned analysis, so to speak, involving 100 patients. And it was presented by Professor Banis Paluchowski from the University of Lübeck, who presented these results at ASCO. Here again are the different methods. So carbon ink is this medical charcoal, so to speak. Probe guide refers to these localizers. The clip is a clip. There is a U-shaped clip. There is this vision clip, the three-dimensional clip, all of that, so to speak. This is a registry study, and everyone was allowed to do as they wished. Or whatever was established as their own standard, so to speak. And it was recorded accordingly and then evaluated in that situation. First, the probes. So the marking techniques using probes, that is localizers, had slightly better results by a few percent overall. Nevertheless, overall, this procedure still worked for 90% of patients. It also worked with the clips. That means they had fewer lymph nodes removed, because the average number of lymph nodes removed was, I would say, about 2, maybe around 3. Not 10, in other words. And even with clips, it was successful in 9 out of 10 women. That is an important finding in all of this. A clear de-escalation. In the past, many more lymph nodes were always removed, because if these lymph nodes, the 2 or 3 that are removed, don't contain any tumor cells, then there's no need to continue operating. I don't even need to
change anything anymore.
That's the key point.
Yes, but what happens if I can't find it? Then I definitely have to remove more lymph nodes.
Well, that does happen to us sometimes in all of this, and there are 2 things that need to be clarified. Yes, you also need to be very familiar with the data. For example, if there is a pathological complete remission in the breast with HER2 overexpression or triple negative, then the likelihood, if you operate again, search for the clip again, or do anything else and continue operating, removing another 3 or 4 lymph nodes, that those will be positive is very low. The probability is less than 0.5%. So you can discuss this individually and often save money.
You also mentioned that most of the time chemotherapy makes the lymph nodes negative first.
Or a lot. So the conversion, meaning that the lymph nodes is actually even more frequent than the conversion in the breast. So in summary, the conclusion of this study is, well, it is important that we have already been applying this over the years in, let's say, certified centers. And the data show that marking the clip, so to speak, provides a high level of safety in all of this. If someone asks, where is this all heading? Yes, that's a valid question. And where things are heading is probably, I believe, in the future, and there are already some initial studies on this, that we will likely only perform the sentinel procedure, maybe not even use the clip at the beginning anymore. So for some patients, we might not use the clip at all. We're already doing that with certain patients. And if it's clinically negative, we only do the sentinel procedure. That's the direction things are heading in.
So clipping is no longer done because it is assumed that a pathological complete response PCR means the lymph nodes are negative.
Well,
but
there's
you
an
really can't
analysis
just
where
assume that,
they
oh, why
looked
don't you
at
clip?
what happens if you only do the sentinel procedure versus doing both the sentinel and the clip marked node.
So sentinel lymph node.
Yes, not the lymph node exactly. Yes, in that context, the difference in survival was minimal. And now there's a Turkish study that was published again at the beginning of this year. You can hardly see any difference anymore. That means there is already a patient population like those with triple negative or other subtypes where today we really need to consider whether to do less or maybe not even place a clip at all. And American colleagues are already doing this. So both approaches are open at this point. That means the clip will certainly become less common in the near future. But what's important for now is to continue with the registry study so that we have now analyzed the marking techniques there, so to speak, with many thousands of patients. That's why we've already published this several times in high-ranking journals. The center study, which was essentially led by us years ago when this procedure was introduced, showed comparable results. And we've already been able to demonstrate the important points, that is the endpoints in terms of survival. That means if we operate less, we don't see more recurrences. And we were able to demonstrate this with the center study, which we also published from our center, so to speak, in which many clinics in Germany participated. So this de-escalation is oncologically safe.
I have another question. If I mark with a metal clip, does it have to be removed afterwards or not?
You also have tons of clips in your body if you have anything done. I don't just mean the screws that maybe orthopedists use or something, but for example, you have vascular clips that remain in place. We have marker clips in the breast for more precise irradiation of the tumor bed, and so on. Nothing happens at all.
It can definitely
The
stay
clip
in.
itself?
I would have said the same, like no metal clip then, because I'd want to avoid surgery if possible. Okay, no, great. That totally makes sense. So what does that mean for me as a patient? Do I have any say in this? Or would you say it's all the same how it's clipped or marked?
Regarding the marking techniques, when you mark the lymph node, then there is the carbon marking as well as the ultrasound guided marking, both with carbon. Far fewer patients were included in the analysis, but it is equivalent in terms of detection rate. That means over 95%. If you use the clip, no matter which one is it, it's around 90%.
Yes. And in terms of the procedure, it certainly makes a difference how it's clipped or how it's marked.
No, it's simply easy to place the clip. So once you've punched, once you've done that, then put the clip in the same one. That's not a problem.
Okay, good. There might be people who think maybe the other way is better since it probably causes less pain. But if you say there isn't a big difference anyway, then...
No, once you've done the biopsy and then go into the same, let's say, to the same channel, then you guide it in and place the clip. Is that now, I would say in experienced hands, it's not, let's say, not problematic.
Yes, great. But the takeaway is that we're back to de-escalation again. And to kind of bring our discussion full circle to where we started, we're actually back at the point where you can say back in the day, they used to clear out the entire axilla, I don't know, decades ago. But now we're at a point where they say maybe less or even none at all. That's obviously
yes,
a really
because we're not there yet
forward.
at all.
Yeah, exactly.
So if we save that time, there are already some initial studies underway, but it still needs a bit more time. But
yes,
even there, that's the direction
that's
things
kind
are
of
heading.
the direction it's going. And of course, that means fewer side effects because with every lymph node you remove, there's a higher risk of developing lymphedema or other complications. That's why it's great. So I'd like to say a big thank you for that. Fantastic news from ASCO, and many thanks for taking the time to go through everything in such detail. And yes, have a really nice evening. Thank you very much.
See you soon.